experience with implementation of surface SGRT, and our experience with lung and liver SBRT with deep inspiration breath hold. As we all know, the challenge of any radiation therapy is try to cure the patients, and this pass through the increase of tumor control with low complications. So we need to give high doses to the tumor and low doses to organs at risk. The last decades have been very important for us because we have seen many technological developments in radiotherapy that give us a very high precision. The accuracy that we obtain with the treatments have been due to the developments in simulation to better define our tumor and organs at risk, with the best dosimetry that we can do now to our patients, very conformal doses with IMRT or VMAT, and also and especially because we can see much better where we are treating, we can verify the precision of our treatment with the image-guided radiation therapy. We not only can control the tumor position, but also the position of the patient during the treatment. This accuracy has allowed us to do safe hypofractionation treatments. We've moved recently in the last year from standard treatments to many tumors in more than 20 and 30 fractions to moderate hypofractionation in breast, prostate, lung, and even we have gone to hypofractionation, not only with stereotactic treatments in the brain or spine, but also with SBRT to other organs like lung, liver, or pancreas. This accuracy is especially important in SBRT because we need to deliver very large doses with highly conformal radiation with a steep dose gradients towards the surrounding normal tissue in a very limited number of fractions. Our experience started in 2007. We started this radiation oncology department, and from the beginning, one of our aims was to start with stereotactic treatments. We started in 2008 with Anovalis. We could do from the beginning SBRT in spine and also in prostate with IGRT based on orthogonal X-rays with the SACTRAC system. And since the beginning, the first beginning, our challenge was to have the same accuracy of SBRT for moving lesions like lung, liver, or pancreas. At that time, we need to use internal fiducials because what we had was a gating system, the SACTRAC adaptive gating system of the Novalis, that allows us to treat the patient in a selected area of the respiratory cycle. These advantages of this compensating technique that we have with gating in SBRT treatments allowed us to have an interfraction control of tumor motion. This meant that we could reduce the CTV margin to final PTV with no need of ITV margins, and this helped us to reduce the healthy tissue irradiated, as you can see here in the picture. In 2015, we moved a little bit more and we changed our SBRT treatments without fiducials in lung and liver, because we started to do deep inspiration breath hold with the active breathing coordinator system of Elekta that also allowed us to have a very high precision by controlling the position of the tumor with interfacial convincity. So till this time, we've been treating with gating and IVC many SBRT lesions in lung and liver, primary and metastatic, more than 500 patients treated, and more than 1,000 lesions treated. But our last step, and I think it's been a step forward of accuracy with this new concept of IGRT, is surface image guided radiation therapy. With the new Versa, we also started with a catalyst system of C-RAD, and with this system we thought, and we have proved, that we can improve our treatment accuracy because with this system we have an interfraction real-time motion management. We have had a full fraction monitoring of the treatment with a continuous auto beam control, and all these things have gave us a very high confidence, especially when we high we give very high doses. The system has 3 cameras installed on the ceiling of our bunker. With these 3 cameras, we have a large patient surface coverage of 360 degrees, even when the couch is rotated, which is very important for us. And this has allowed to have a very fast setup and very high precision with patient positionings. Our RTTs feel very confident because they reduce setup time. They very quickly go to a route position to isocenter with the visual references without the need of tattoos, and automatically this deals out to coach translation to the precise isocenter. So this automatic alignment procedure, just for all the patients that we've been treating in this LINAC, it's been very intuitive and easily integrated into clinical environment and has optimized our workflow. We also ensure the patient safety. We are continuously in real time doing the motion monitoring. We control the interfaction patient movements, and the beam is switched on and off if deviation values are larger than the tolerance level we have predefined. We can also, which is important, we have a documentation of outs of tolerance movements. And what we've done recently is to analyze this interfaction deviation and the tolerance levels of the catalyst surface SGRT that were given to us when we started. We wanted to optimize these tolerance levels. We presented this as a poster in Astron 2019. We studied 126 patients with different tumor locations, a total of almost 2,500 sessions, and the equivalent of more than 200 hours of monitoring. And what we found is we analyzed a variety of percentages of the time within a tolerance level of deviation, and at the tolerance of 90%, 95% of the time in the different locations, breast, thorax, abdomen, pelvis, extremities, or cranial, we saw that we could reduce even in 1 millimeter the tolerance values compared to the predefined values given by a catalyst. So nowadays, the tolerance of isocentership that we have for brain tumors of head and neck and less than 2-3 millimeters, we feel very confident with that. We also have this the tolerance of isocentership below 4 millimeters in most of our pelvis treatments, rectum or prostate, as you can see here. This level of tolerance could in many cases even be reduced. And in other locations like abdominal or retroperitoneal tumors, and even in breast and thoracic tumors, our tolerance of isocentership is below 5 millimeters. But in those locations, we also use deep inspiration breath hold, because sometimes we need to be very sure we have organs at risk very close, as we have in breast irradiation and left breast irradiation, and when we treat lung or liver lesions. So till now, in these 2 years of experience, we've treated with a catalyst SGRT more than 1,200 patients, and we've done more than 145 patients, more than 30 with just breast standard fractionation in 15 or 5 fractions, and more than 70 SBRT treatments with lung and liver. For doing this deep inspiration breath hold, we have a Sentinel 4D CT installed in our CT room, which allows us to map the surface of the patient. What we do in the CT simulation is to define a reference point to monitor breathing and train the patient to take a deep breath within a 4 millimeters gating window, As you can see here, we use goggles to train the patient. This helps us, and regardless the age of the patients, it seems quite easy for them to maintain the breathing in this gating specific window. When we have trained the patient, we can do the acquisition of the CT images in this deep inspiration breath hold into this gating window selected that we have decided to be 4 millimeters. As you can see here, the images are acquiring at the same time that we are in the gating window, and in certain tumors, for example, this one was a patient with an hepatocarcinoma. We have to take 2 different phases of the images in arterial and venous phase of the contrast. So you can see here, we had the arterial phase and venous phase, as you can see now, without any problem and with very high accuracy for the delineation of the tumor. So this situation allows us to keep these tight margins from CTB to PTB of only 5 millimeters with no need of ITB. For lung and liver, we still are treating the patient with same accuracy that we had before in 3-5 fractions, single lesions, multiple lesions, primary metastatic lung and liver, to high doses up to 60 gray. And this is an example of an SBRT with the deep inspiration breath hold with this catalyzed respiratory gating. The patient, as you can see in the video, is taking a deep breath to reach the gating window. The beam turns on when the breath hold is on the gating window. And the advantage of this technique, I think, is we have a double intrafraction motion management. We have 2 monitors that allow a specific tolerance. The first one, the above one, is for the control surface of the patient, and the one below is to control the internal motion with gating during the irradiation in the venon area. In addition, and we think it is very important, we have connected this catalyst system and this gating system with the LINAC, with the Versa of Electa, and we can do intrafraction combined CT by the time the patient is being irradiated in this selected gating area. These are examples of some of intrafraction combined CTs for lung and liver, and we have done also a very preliminary analysis of these intrafraction combined CTs in different patients in lung and liver lesions. And what we have done is to analyze the data obtained from the intrafraction shifts in Mosaic, and we have analyzed 10 treatments of lung SBRT, these combined CT shifts, and the average correction, considering that we have treated upper and lower lobes lesion, is an average correction of 1.7 millimeters. And for the liver, we did the same with another 10 treatments, and the average correction is higher, a little bit higher, 3.5 millimeters. Also, the lesions were in different segments of the liver. We correct after this intrafraction verification all the next arc. So in conclusion, in our preliminary experience with catalyst surface SGRT, we think we have done a step forward for the accuracy of our treatments. We found it easy to incorporate in our clinical practice. We think it improves patient setup and allows markless positioning. Also allows intrafraction real-time motion management, has given us high confidence when delivering high-dose treatments. And SGRT with deep inspiration, breath hold, and gating for lung and liver is feasible and give us a double control of the surface and the tumor position. And this intrafraction combined CT further increase the accuracy by correcting these small shifts. And thank you very much for your attention.
Thank you so much for that presentation. That was brilliant. We will now open up for a Q&A session. So please unmute yourself and go ahead and state your questions. There's also an option to ask your question directly in the chat, and I can read that out for Carmen to answer. So I do have a question. I mean, I like the presentation a lot. I believe that there are many people and clinics around that is trying to implement SGRT to their clinics as well. And that would be happy to hear a little bit how you were, your thoughts regarding the tolerances and how you came to the conclusion of the different tolerances that you optimized for your treatments. Sorry, I believe you muted yourself right now. We can't hear you.
Sorry. Can you hear me now?
Yes.
Okay. Thank you. As I said in the presentation, we analyzed. We had several established tolerances that were given by C-RAD, but we analyzed the time, the percentage of the time that the patient was within one tolerance in these 126 patients, I think. And we saw that the time that the patient, the 90%, 95% of the time, the patient was below the level that was given by C-RAD. That's why we allowed our tolerance to go down at least 1 millimeter. So for cranial treatments and head and neck, we have 2 millimeters now. For pelvis, we have 4 millimeters, and for lung and abdominal, we use in many cases, although if it is a more standard treatment, we can use these 5 millimeters of tolerance. We reduce it by using deep inspiration breath hold, especially if we go into hypofractionation or SBRT, of course.
Thank you so much. We received some comments from Angel Montero. Congrats, Dr. Rubio, for excellent talk. Thanks a lot. So just positivity sending your way. We also got a question from Annelie. How do you check the internal reproducibility of the tumor during the treatment delivery in DIBH?
Yeah, as I've always presented, what we do is a prepositioning a combing CT to make sure that we are in the liver, or in the lung is very easy because you can see the tumor very nicely. And then of course we do an interfacial combing CT for all the patients before we do the second arc. Most of our treatments have 2 arcs, sometimes 3, but in most of the cases with 2 arcs, we do an interfacial combing CT, and we correct. We verify the shape of the liver in the case of the SBRT treatments of the liver, and because we cannot see the tumor, of course, but we can very nicely see the shape of the liver, and we, with this registration system, we correct the shift in all the cases. So we feel confident because this combing CT is doing during the irradiation of the first arc. And the correction, they are not, we still have to study more cases, but these 10 preliminary ones where, you know, the movement we changed was 3 millimeters, and we are in our PTB margins of 5 millimeters. So we feel quite confident with the treatment.
Thank you. We got another question from Siri Mørkestedt. Is the gating window 4 millimeter in both breast and lung? Have you considered a smaller window?
We have considered that, but as you see, this system of deep inspiration breath hold doesn't keep the patient in apnea, so the patient can move a little bit the breathing within this area, and I think 4 millimeters is it's a good idea. I mean, if they were too tight in certain patients, we could have problems of being with the being in and out all the time.
Thank you. Yeah, we got a thank you here, and both from Anneli and Siri on that regard. Let me just take the opportunity to thank you, Carmen, so much for your presentation and the very nice Q&A session here. There's no other questions popping up, just positivity and thank yous to you, Dr.